Hello and welcome. This is Dr. Tom Moorcroft. I'm so glad that you're joining me today for this introduction to Lyme disease. And really, this is a modern epidemic. We're going to kind of really spend some time diving into the different aspects of Lyme disease, things that you might be seeing in your clinical practice, things to be aware of to both keep yourself and your family healthy and to do the very best for the patients that you're working with. So again, I'm Dr. Tom Moorcroft. I'm the medical director and co-founder of Origins of Health and Osteopathic Wellness Center in Berlin, Connecticut. I've also created a bunch of programs, including the Leave Lyme Behind Mindset Healing Program to help patients overcome those hidden sort of things that are holding them back from healing from Lyme. Those pieces that are outside of exactly what might be, things that we're giving them from a medical or an herbal perspective, but the parts that really empower them to take back control of their lives. And also I've running a Lyme disease practitioner certification program and mentorship where I walk practitioners through really how to start to finish, how we really look at people with tick bites, acute Lyme disease, and most importantly, in that program, how do we address chronic Lyme disease and other chronically acquired environmental illnesses. So I'm really excited to be here today. And through the course of the talk, we're going to be talking about things like how significant is this Lyme epidemic. We're going to talk about whether or not prophylactic treatment should be ordered or not if someone does have a deer tick bite. Talk about a little bit about the clinical presentation of acute Lyme disease. So, kind of what to be aware of when people come in your office. We're also going to talk about treatment options. And one of the things that I wanted to do is make sure that I give you some pharmaceutical as well as some herbal treatment options. And when we get to it in the lecture, I'm going to flash through some of the slides. They're going to have the dosages there. I'm not going to go and read through every dosage. I just want you to have them as a reference and know the general classes of drugs and herbs that we're going to be using. So you'll have everything for your reference. So hopefully that'll be helpful. And then, let's talk about next steps. After we get past prophylaxis and acute Lyme, what else is out there? We're going to talk a little bit about chronic Lyme and co-infections. So the question is really, how big of a deal is this, right? And so back when even 10 years ago, we were estimating that there are like 35,000 new cases, some years even 25,000 new cases of Lyme disease. And what we're seeing now is that the CDC estimates are really closer to 500,000 people in America are getting diagnosed and treated for Lyme disease every year. And really this number continues to climb. There's also this discussion of after acute Lyme disease, about 80% of people are going to get completely better. But then there's this other 20%. What happens to them? And there's a large number of people who they may have a thing that people are calling post-treatment Lyme disease syndrome. And there's been studies out of Johns Hopkins that says, hey, this really is a real situation. Right. So people who have been treated for Lyme, have symptoms, they can't find evidence of active infection. And granted, they're doing standard testing, which is known to miss about 44% of all true positive cases. But that withstanding, they've figured out that this is a real thing. And so then there's post-treatment Lyme syndrome. And my opinion, the opinion of many, many people, is that most of these people probably have chronic Lyme disease. So an ongoing infection, or potentially a combination of post-treatment Lyme, some temporary ongoing inflammation and immune dysfunction along with an active infection. So we could have a little of both. But the question is how much is this? And really, it's almost 2 million people by the end of 2020. I mean, this is a massive number. So we not only have escalating numbers of cases of acute Lyme disease, but we're also having really super high levels of people who are suffering with chronic illness that could be potentially transmittable. So the thing I really want to focus on today is identification of people with tick bites, how to appropriately address those to minimize the chance of getting Lyme at all. And then if you do get acute Lyme, how do we treat it so that we don't end up becoming just another statistic of chronic Lyme or post-treatment Lyme syndrome? So one of the things that we do know is that Lyme disease has a preponderance of, going after 5 to 15-year-olds. And as you can see from the graph, males more than females. So if you have young men and young boys, either your own or in your practice, these are things to be aware of. And then also the age group of 40 to 60 is a bit of a big deal. So this is a place where we want to keep in mind that it's like young kids and their parents or their young grandparents are the people who are getting, Lyme most. The other part we want to remember about is that, we talk about where's Lyme. Well, we know mostly the Northeast is a hot spot, right? But there's also the Midwest. And then the rest of the country, the other 40, all 48 contiguous states have found cases of Lyme. And with habitat changes, with migratory birds and disruptions of their patterns, these ticks are starting to really take hold in other places. And Arizona and California, as an example, are really hotbeds of growth. And so there's a bloom of people, a bloom of ticks are infected with Lyme in different places. And we're also having this migration of these infected ticks bringing Lyme to areas that they traditionally weren't. So these are things we need to be aware of. Another thing I want to just really briefly touch on, and I want to thank the Tick Encounter Resource Center at the University of Rhode Island and tickencounter.org. They have great resources. And one of the things we have to be aware of is there are more than just one kind of tick. And so primarily the agents that transmit most of the diseases we think about are Lone Star ticks, dog ticks, and then the Ixodes ticks, which are the black-legged ticks or the Western black-legged ticks. So they're things to be aware of, that there are other ticks, and you can go there and see some of the other ones. Just as a quick kind of public service announcement, most of our ehrlichiosis, pretty much all of it, is being transmitted by a Lone Star bite. Now, Rocky Mountain spotted fever is found and has been documented to be transmitted by Lone Star ticks. Also, Coxiella burnetii leading to Q fever, and Stari borreliosis, and potentially even alpha gal, the red meat allergy, can come from a Lone Star tick bite. Now, with dog tick, typically is going to carry Rocky Mountain spotted fever, very, very infrequently tularemia. These are things to be aware of. So the thing to know about both Lone Star ticks and dog ticks is their infectivity rates are relatively on the lower side, but when they do, they can have life-threatening or potentially life-threatening infections like the Ehrlichia and the Rocky Mountain spotted fever. When we talk about Lyme disease, it is coming primarily from the deer tick, almost exclusively, and we'll touch on that. But the black-legged tick and pretty much any Ixodes tick in the United States is going to be carrying some of these pathogens: Lyme disease, Babesia microti, Babesia duncani, anaplasmosis, Borrelia miyamotoi, and even Powassan virus. Now, there's been some other infections that have been found in them, but they're kind of like early in phases of figuring out even if they are human pathogens. But with the example of Borrelia miyamotoi, we didn't really call it a human pathogen until February 2012, but we know at least 30 years prior to that, we knew that they were in deer ticks, and it looks like, looking back in the literature, that Borrelia miyamotoi infections were actually there when people were thought to have Lyme disease, but it turns out that they were negative for Lyme. And then in retrospect, after we learned more about Borrelia miyamotoi, looked back on those blood samples, they actually had Borrelia miyamotoi. So it's something to be aware of. There are co-infections. We're going to focus on Lyme disease because the deer tick, or the black-legged tick, is most commonly infected tick in the country. And Lyme is the #1 vector-borne disease. And what's really important to understand about this is, depending upon where you are, there's different infectivity rates. I'm in Connecticut primarily, and we see that depending upon the year and the group doing the research, we have anything from 30% up to 50, 60%, and even a couple of years we had 70, and 1 year, 90% of the deer ticks surveyed in different plots across Connecticut were infected with Lyme disease. Typically, any of these other viruses or the co-infections that are bacteria or parasites like babesiosis, we're really looking at less than 10% infection. So Lyme really is the #1, and that's why we're going to focus on it today. One of the things I want to point out is, if you go back for one sec, the adult female on the right and on the bottom left, the nymphal tick, these are the two that are transmitting Lyme disease to humans. The males do not. The larvae very infrequently infected with Lyme disease. They could be infected with Borrelia miyamotoi transo very early, but the thing is, they're not biting us. They're kind of too small, hanging out in the leaf litter, and they're looking for smaller rodents that they can get on. When we look here, we see on the right the adult female, on the left the little nymph, and I just want to give you a perspective of size, and you'll understand why Lyme disease is, pretty much, research says that 90 to 95% of all Lyme is transmitted by the nymph, which is the one on the left. So one of the things I like to do is remind people that the nymph is about the size of a poppy seed. We've got a poppy seed on the top left there, a little pile of them, and then we have a magnified version. And if you've looked at this for a little bit, maybe you found that little deer tick nymph, but this is an blown up version. Look at that. It is literally the size of a poppy seed. And that's a bagel, I guess. So one of the things we have to remember is that these are really hard to find. Once someone does get bit, the question is, how long is it attached for? And realistically, the thing is, everybody says, oh, it's got to be 36, 48 hours. That's actually not true. We know animal models transmission occurs in less than 16 hours, and no one's ever really established what the minimum, attachment time is. One of the pieces that I do want to point out here is that there are studies showing transmission of anaplasmosis can happen in as little as 8 hours. Some of the soft belly ticks that transmit Borrelia hermsii can do it within 15 minutes. Typically, though, what we're going to see is in the first day, we're not going to see a lot of transmission, right? But it's not none. And it's estimated to be about 5% of infected ticks will transmit in the first day, and nymphs will feed for about 4 days. And by the time you get to day 3, it's above 70%, and day 4, it's above 90%. So transmission rates are higher later on for sure, but it doesn't mean there's none. And, you can dive into why it could happen early. We also have at least 3 cases in the medical literature. I have cases in my practice less than 24 hours. So I live in a Lyme endemic area. Any deer tick bite is a high risk bite. Certainly a big, really, engorged one is going to be much more of a risk than a flat one, but even flat ones could potentially have already transmitted Lyme. One of the ways that you can minimize the risk of transmission if you have any tick, but particularly a non-engorged tick early on, is to actually remove them properly, which is to grab the mouth parts as close to the skin as possible, preferably with needle nose tweezers, grab them, lift and hold. And the reason we want to do that is that hypostome, that mouth part that's in the middle, is barbed, and the tick needs to release those. And so it could take, if it's really in there, it could take a minute or 2, maybe a little longer. So just little gentle pressure up, it will release. This minimizes the risk of mouth parts being in place and such. Now, 2 things I want to point out. One is we don't want to sort of do the essential oils, the burning, the smothering, or any other kind of twisting, rubbing, or other baloney you may have heard out there. We just increase the risk of the spirochete that causes Lyme disease that lives in the tick midgut of being shot by the tick into you, because as you can tell, the barbs are to keep the tick in. If it needs to emergency release them, what you need to do is basically vomit into you. So we want to minimize that, because right now, if you start to piss the tick off, you were not infected, now you are infected. The other thing is, this actually is the best picture I was able to find after hours of searching. And it is actually a dog tick, not a deer tick, but just in case anybody happened to pick that up. But the removal is the same. Now, what do we do if we get bitten, right? So there's this study out there for single-dose doxycycline, and it says there's about an 87% efficacy in that study. The issue is single-dose doxycycline was looked at to prevent an erythema migrans rash, and the problem was that was a surrogate for preventing Lyme. The study was not designed to figure out if someone who did not have a rash actually had Lyme disease, which is problematic because in the medical literature, the CDC says only about 70% of people have the rash. The research shows it's only about 40 to 60%, so call it 50%. And in clinical practice, it's really more like 15 to 20% of cases of acute Lyme are presenting with the rash. So this is problematic. So all of the subjects in this study who did not have an erythema migrans rash were assumed to be negative. The problem was we had 3 subjects who seroconverted and had clinical symptoms of Lyme disease with no rash, which just means that the study proved that that its main sort of surrogate for prevention of Lyme was not a validated one. Yet we still go on and say, hey, let's do it anyway, which is complete craziness in my opinion. And the other thing is failed treatment of the single-dose doxycycline in one patient actually led to seronegative Lyme disease. So we had no rash, we had no blood tests, but they developed Lyme. And now the problem is those are 2 of the easy ones that help us in clinical practice pick out acute Lyme. And if we do single-dose doxycycline, we can prevent it and the patient can still have the illness. The other thing is there was a 6-week observation period. The problem is some of the late manifestations of Lyme take weeks or months to develop. So the next best studies to look at outside of human studies, single dose doxycycline in mouse studies, it was only 43% effective. And if we happen to add anaplasma into the mix, so we had a co-infected tick, prevention of Lyme disease was 20%, prevention of anaplasma was 30%. So if we go and we look at further at other mouse studies, we say, hey, if we inject them with doxycycline, which is equivalent to last acting for, for us taking 19 days worth of doxy, we can prevent Lyme and anaplasma both 100% of the time. So what most of us have done, because this is literally the best evidence we have so far, is we presume that treatment of Lyme, should be done, prophylactic treatment would be done with doxycycline 100 milligrams twice a day for a minimum of 3 weeks. And most experts recommend at this point 4 to 6 weeks, and then reassess your patient. In my clinical practice, I typically, offer 3 to 4 weeks. I make that choice based upon how long we think the tick was attached and all these other good things. How robust the patient is. But really, the most important thing is we give them a minimum of 3, probably better to do 4 weeks, and then reassess the patient. And if I do even think I'm going to do 6 weeks, I'm still going to reassess them at the 3.5 to 4 week mark. The reason that we use doxycycline, even though many of you may know it's bacterial static at this dose, is because it covers more than one of the infections, including anaplasma, which can be pretty brutal. And a lot of our other medications that would hit Lyme would only hit Lyme. Notice that we're not covering for babesiosis in here. It's really hard to do that. There's no studies really on prophylaxis, so we have to keep that in mind. But Lyme being the number one, we want to hit that. There is some talk about using doxycycline 100 milligrams, 2 doses twice a day to get 200 milligrams of potentially being bactericidal. And, in some pharmacologic pharmacokinetic and pharmacodynamic studies, that does look like it may be the case clinically. I haven't found that to be necessary, but it's out there. Alternatives to doxycycline, especially in the summer, might be minocycline. You have some of the others listed. Azithromycin is not a first-line agent. None of these really are, because we're missing those other co-infections. If we do, basically, there's really no studies in children, but we do sort of try to extrapolate. My biggest issue is extrapolation of using the single dose in young children. I just don't think works. So I would rather just treat the children with an appropriate weight-based dose and monitor them. There's always, the patient preference has to be taken into account. We also have to understand, what their preferences are, whether they want to watch and wait or do true prophylaxis with treatment. And we have to let them know that, the studies are lacking. And we also have to think about what we could do to their gut. Generally, these antibiotics are tolerated well, but I would use probiotic during it, as well as for at least double the duration. So if I treated them, say, for 4 weeks, I would ask them to be on probiotic, definitely 40 billion or more. Well, in an adult, and in children, back that off based upon their weight. But I'm going to ask them to do that for the duration of the treatment, call it 4 weeks, and then for 8 weeks thereafter, to just make sure we've rebuilt the gut from anything we may have done. I tend to use amoxicillin or cefuroxime if they're under 8, but if you believe that they have anaplasma, Rocky Mountain spotted fever, or Ehrlichia, depending upon what they got bitten by, we don't hold off on using doxycycline, and check out the CDC review of that. But using a 7 to 14-day course, depending upon the infection and the clinical presentation, with fever and such. And this is really doxycycline under 8 for prophylaxis. I don't use. This really kind of jumps us over a little bit into acute treatment. Because realistically, if they're having a fever, or you think they have Ehrlichia or anaplasma or whatever, Rocky Mountain spotted fever, we're actually doing acute treatment. But anyway, I want to make sure it's in here that we have the discussion. Prophylaxis, I don't do under 8. I do treatment, and then I follow the CDC recommendations for the initial stages of that rickettsial infection. If you wanted to do something like an herbal approach, I like MCBB2 from Beyond Balance, VitalGuard Supreme from Supreme Nutrition, and Cryptolepis. I use Lymecore Botanicals out of Connecticut. They're excellent. You can also use one from BioPure. They're the 2 highest quality ones I've found. And certainly these are adult dosages, and I'm going to show you how to modify them for kids. The other thing is, if you use Byron White, you can use something like AL Complex. Crypto Plus is something that is from Research Nutritionals. Certainly, if you want to double check your covering for babesiosis, cryptolepis and or Artemisia are really good and helpful. And Polygonum cuspidatum, which is also known as Japanese knotweed, growing in my yard, unfortunately, and probably many of yours, an invasive species. It's very good for Lyme and Bartonella. And cryptolepis is really good for Lyme, Bartonella, and babesiosis. So when we look at this coverage here, we can hit Lyme, we can prevent for some of the co-infections. So a lot of times what you'll see me do is, even in a prophylactic formula, I might do doxycycline with cryptolepis or doxycycline with BB2 and cryptolepis, you know, when you want to get a little more advanced in there. I just listed a couple of these for you so that you have the option of looking at them, figuring out the dosages, whether you're using whole herb, liposomal, tinctures, etc. And if you're going to do tinctures for your kids, we're assuming an adult takes 30 drops total, you know, or we're doing the ratio with that, and they're 150 pounds. So basically, if your adult dosage is 15 drops, then you would change that 30 drops to 15 drops, and then you would do the thing. And same idea comes up with the capsules. If you have a kid who will take capsules, you can make some changes based upon this general ratio. Now, the clinical presentation of Lyme, everybody wants to find erythema chronica migrans, you know, and again, I said it's not there that often. This is your typical bullseye rash. The problem is this is also an erythema migrans rash. And so is this. And now we can have multiple. So we have a central clearing with a ring, but we don't have actually a bullseye. And here we have an erythema migrans rash in the middle, and on the left of the screen you see there's another one, and there's the pulled out version. That can also be Lyme disease. You know, not a bullseye, not even remotely close to a bullseye. So bullseye rashes are only about 20% of true erythema migrans rashes. So just be aware of that. When we think of clinical presentation, we break it down into these crazy little things like early localized, early disseminated, and early and late disease. But what really the thing to think about is the things that a lot of people think about, neurologic and arthritis, may be, you know, medium term to much longer term in presentation. And our flu-like symptoms, you know, those are things that pop up, and they're really important to understand that you can have summer flu, which is typically Lyme, but in an endemic area, but also you run into the situation of, like, some people get bit August, September, and they don't start having symptoms till January or March. And there are actually cases reported to the CDC, confirmed cases that meet their research criteria every month of the year. Certainly there's a spike in the summer and the fall, but every month of the year we have true cases of acute Lyme disease that present. In the neurologic department, Bell's palsy is one of the number one presentations, but we also have a bunch of other things, and any kind of cranial neuropathy, it loves cranial nerves. So just keep that in mind, particularly the facial nerve. And then also we will see a lot of vagus nerve dysfunction. So we can have heart rate, tachycardia, we can have palpitations, we can have the sense of a racing heart rate. And so we can lose a lot of our, central nervous system and respiratory control over the heart rate through that vagus nerve channel. Certainly, we've all been aware of AV black is kind of like the biggest thing with the cardiac abnormalities, but we have a lot of other ones, and sometimes even sudden cardiac death. Typically not the most common things, but be aware they're out there. The biggest thing I wanted everyone to be aware of is that when we look at this, cardiac abnormalities really are probably not as common as the cardiac symptoms, as I just mentioned, through that vagus nerve pathway. And this is where patients get really freaked out. You need to be aware of both, but also be aware of that so you can help people calm down a little bit and understand that we're going to evaluate for the cardiac. And then if we do have some of this cardiac stuff coming, we'll keep reevaluating to make sure this isn't a problem. But a lot of times it's more the vagus nerve control over the heart. What I see commonly in clinical presentation is arthralgias and myalgias, brain fog, numbness and tingling, and some of these other symptoms here. One of the things I really want to point out is that GI distress is a big deal, and we see leaky gut and food allergies often caused by Lyme that was missed initially. This is not a presenting symptom of acute Lyme typically, probably could be, but these are more the people who are initially missed. But just be aware, I've treated people who their main symptom of Lyme was food allergies. We treated them, all their food allergies went away despite using an antibiotic to do it. The other thing is Dr. Horowitz did an amazing job really trying to figure out what separates Lyme from other things. And migratory joint pain and migratory paresthesias are really up there, with migratory joint pain really being the key indicator for Lyme. The very small differential of inflammatory bowel disease, gonococcal arthritis, and hepatitis. So when you look at this, check those out. But if they have migratory joint pain and or migratory nerve type pain, it's probably Lyme disease, particularly in an endemic area. In children, I'd say about half of the cases I see present with a GI complaint. One of the things to make sure you're aware of so you catch it every time, isolated abdominal pain without a clear etiology is very commonly Lyme disease, especially on these kids who've done these multi-million-dollar workups and no one knows what's going on. The other thing is Lyme can trigger PANS, which is pediatric acute onset neuropsychiatric syndrome, a type of infection triggered autoimmune encephalitis. And that can lead to behavioral changes, regression, everything from reading and handwriting to behavior, and even tics, often with the hands in the face, grunting, snorting, vocal tics, flapping of hands and such. Very, very similar to what you would see in pandas, which is from strep and Sittingham's chorea. Keep in mind, Lyme, just like most other things in medicine, is a clinical diagnosis supported by lab data. So if it looks like Lyme, if it talks like Lyme and walks like Lyme, it probably is, because our lab data really isn't that great. And we do miss a lot with our labs. As I mentioned earlier, our typical two-tiered screenings test misses 44% of true positives, and that was shown in a meta-analysis. And it's just important to know that these things support us. And the problem is really, if you're in an acute area, and if you're in an endemic area and you see acute Lyme disease symptoms and signs, you should treat them. Because if your pretest probability of having Lyme disease is greater than 80%, the likelihood of a false positive is extremely, extremely high. And even in really endemic areas with the increases we've been seeing, your false negative rate, even if you're like 65% sure it's Lyme, you probably should treat, especially since people are treating acne for over 5 years with the exact same dose of medication. Giving someone 3 to 4 weeks of an antibiotic to do your very best to prevent them from even ever getting this infection, or treating it a bit longer, which we'll talk about in a minute, on how to treat to really eradicate acute Lyme. We need to do these things. I mean, it is, in my mind, medical malpractice to not be offering them something that's a relatively safe treatment. We let them know the risks and the benefits. We give them the probiotics. We keep an eye on them. We are not leading to more resistance by giving people these 3 and 4 week courses, 6-week courses, 3-month course of antibiotics. The problem is when you put them on 2 days for this or 2 doses for this crazy prophylaxis where you double it down once, or you do them 2 days and you say your testing is negative. Well, no kidding, it's negative. It's acute Lyme. The test isn't even positive for 3, 4, 5, even 6 weeks out. So if we have these people early on, don't withhold treatment. The treatment, again, doxycycline in acute Lyme, we're definitely going to give them, at least 6 weeks in my opinion, usually more like 3 to 4 months. And I like to treat them for 4 weeks and then a minimum of 4 to 6 weeks, but then treat them 2 months after they're symptom free. Now, this might sound a little crazy. So I give them, antibiotics, 3 weeks in, they're completely asymptomatic. I'm going to give them 2 more months of antibiotics. And it's really important to understand there are persister forms. You can get persister forms early. Let's eradicate this thing. I mean, if you're giving somebody 5, 6, 10 years of doxycycline or minocycline, 100 milligrams twice a day for freaking acne, you can certainly try to prevent this. This is like one of, if not the slowest growing infection that we know of. And it's the #1 vector-borne illness in the country that can lead to significant disability. So let's err on the side of caution. Now, if there's a reason not to do it that long, and then you treat them and then you monitor them, that's great. Everything should be individualized. And again, also there's some alternative dosing. Here's some of the alternative dosing for the herbs as well. This is more the acute versus the other one we looked at was prophylaxis. So in summary, really what I wanted to do is talk about how common Lyme disease really is. And it's super common, right? And if you live like in the Northeast, or if you come to Connecticut, I mean, the question really isn't, have you been exposed? The question is, are you having symptoms of Lyme disease now? And that's the thing. So become well aware of the symptoms of Lyme. And I understand, we kind of breeze through some of the most common presentations so that when you see an acute case, that you're going to catch it and then you're going to treat it to eradicate it. We don't need to do these persister protocols. We don't need to do double dose dapsone. We don't need to do methylene blue and all this other stuff. Give them some doxycycline, maybe layer in some cryptolepis, and that's nice and easy, very safe, very effective. You're going to hit persister forms in case they happen to be transmitted early, because there is some evidence that can happen. The bottom line is treat to eradicate. And certainly please offer prophylaxis if you're comfortable with it. If you're not, refer them to somebody who is. I'd love for you to start that within the first 5 days after a tick bite, maybe a week out. Send things into, have the tick tested if you can, somewhere like tickreport.com or one of the other ones. There's a lot in Pennsylvania now. It's really good. Get those tested so you know. Now, one quick piece is if you start prophylaxis with herbs and the tick comes back negative, feel free to stop those herbs. If you start prophylaxis and 3 days later, the tick comes back negative for anything, including Lyme disease, and you're on, like, say, doxycycline or another antibiotic, I generally ask them to continue for 7, probably closer to 10 days, depends on which antibiotic you're giving, just so that we minimize the risk of leading to resistance of other organisms that the antibiotic would potentially be in the process of concurrently treating. And so I kind of just hedge bets there just to be on the safe side. The other thing is, please do everything to prevent chronic Lyme disease. Having had it, and this is my specialty, I want to make sure that people don't end up with chronic Lyme. The other thing is, please understand, this is not the be all end all. We've got diagnosis and treatment of chronic Lyme disease. That's another place you can certainly check out some of the information that I have, and I'll tell you where to get that in a second, so that you can really understand that. But the best part is to prevent Lyme and to prevent chronic Lyme as best we can. Co-infections are also more common than often reported. So that makes the presentation more complex. As we saw in the prophylaxis treatment, it makes prophylaxis more complicated. It makes treatment more complicated, and the diagnosis is harder. So these are places where, when you get comfortable with the most common vector-borne illness, Lyme disease, which is the number one thing we need to be working on, these other ones we can start layering in. And I'm certainly happy to help with that. Check out LymePractitionerCertification.com. Our current class is closed, but we're certainly love to get you on the waiting list. And the good news about getting on the list for that is I drip out different educational material that you can check out. My clinical practice is originsofhealth.com. And also on YouTube, I've got a lot of educational videos and many, many more coming. So check out youtube.com/originsofhealth. And if you want to know more about me and some of the other training programs we're doing, check out tommoorcroft.com. Thank you so much for having me today. This is a pleasure, and all the best to you, your families, and all your patients.